absolutely less than 30 minutes, hopefully around 25, and then we can have any questions and answers. And then we'd ask you to take any when you've learned back to your colleagues in the department. Could we share the slides, please, Sarah? Okay, so slide 3. So a couple of bits from me first, and then we'll go into more specific pieces of work through the various exec colleagues. Next slide, please. So the first one is a rather wordy way of describing something that we're seeking to do with our partners. So you've heard of, I'm sure, the 10-year health plan that government launched around maybe 6-8 weeks ago. And this is a kind of subset of that. So what this is seeking to do is say that in your street in which you live, there will be a double figure number of organisations providing services to that street. So today across our system, there will be there is a children's commissioner, acute healthcare commissioner, a community healthcare commissioner, a social care commissioner, an ambulance service commissioner, a mental health commissioner, a voluntary sector commissioner, a specialist services commissioner, and various others. I could keep going to a double figure number. And of course, that gets the results it's designed to get, which is it does lots of good stuff, but it can often be disjointed. And what the population experience is that disjointedness. And it doesn't use our resources very well as a group and a public sector collective. So this is about saying in your street, rather than do that, why wouldn't it be interesting if there was one individual and one construct that was commissioning all of the above for the whole street? And for street, obviously then read estate, village, town, neighbourhood. So we applied with 13 other partners to be part of this programme, and we were one of a small group selected, and we're very early into that. And it's not, although the word health's in the title, it needs to be more than just health. So I often use the example of the women's outcomes agenda, which starts way back with education, housing, poverty, vulnerability, violence, exploitation, prevention, health, and it will include gynecology, surgery. But that's a very small part of it. And so we've got a role to play as a health partner across that whole spectrum. So this is us really seeking to get ahead of that policy and say, right, how could we behave differently as an NHS? We can't keep perpetuating the NHS we've got. That's the first line in the 10-year health plan is the NHS is under existential threat if it continues to behave in the same way. So we cannot keep doing the same thing. So that's what that one is. The second one's a national maternity and neonatal investigation, now referred to in the media as the AMOS inquiry. So Baroness Amos has been asked by the Secretary of State to examine when things go wrong in maternity and neonatal care. And so it came as a surprise to the Trust that we were part of that. We'd been expecting not to be. But that's where we are, and that's okay. And there's 3 things that the Trust is now really committed to in that. One is that we are and will remain very humble around the times that we didn't get it right in this part of the world for women and families. It would be wrong of us to think that was in the past now, and we just move forward. So we will be very humble and will contribute to the inquiry diligently. There's also something for us to learn. So there are other trusts in that who currently are under significant scrutiny, pressure, investigation, and some who are not. So there will, like anything, I guess, we will certainly learn from others and learn where things are good that we might want to bring here and where things haven't gone so well that we may want to reflect on. There's also the opportunity for us to contribute. So the Trust on a number of measures, not just our assessment, the maternity support programme, the nationally mandated programme, the trust is about to exit that programme. Arrangements to be confirmed, but the trust was certain about before the announcement of the investigation was about to exit that, so it's a positive sign. The National Experts in Maternity and Bureau mandated support now. And the CQC inspected our 3 sites for maternity in the summer, and we're awaiting the written feedback. And the verbal feedback was very positive. They described the care that they saw as good, so we took comfort from that. And then our maternity patient and service user survey for the last 3 years has been better each year sequentially. So our population are telling us that at a high level that we get it right. Of course, we don't always get it right. So this is not us saying that everything's perfect, of course not. But we can evidence, and we're being given feedback from experts and the population. They're also experts in their care, that we are good in getting better. The key thing for us is twofold. One is public reassurance. So when families who are considering having a baby or are currently looking forward to having a baby, then the question is it safe in Morecambe Bay? Is this Morecambe Bay not safe again? The answer is absolutely not. It's not that. This is for all the reasons mentioned. We can give a very strong assurance that our services are safe and high quality for women and families. And then secondly, for our staff. So the reason that I can say all of the things I've just said is because our staff in maternity and more broadly, neonates, paediatrics, obstetrics, have done a huge amount of committed work under real pressure to get us to that place. And so it's ever so important that we support them and acknowledge that this will feel difficult, but that we are right behind it and right behind it. The third bullet point I've covered, the maternity CQC inspections. We also in the summer had 2 CQC inspections in our urgent care. So emergency departments, acute medical unit, same day emergency care, both at Furness and at RLI. So again, the feedback on the day was stuff for us to learn. There always is. Inspectors inspect stuff, so they find stuff, and we listen to that and try and make ourselves even better. But the feedback on the day was that they saw under real pressure, they saw compassionate and quality care. So we see what the written report says, but the verbal feedback was reassuring. Financial, so this is a perennial issue. You will have heard this over many years successively, and the money is really challenging, and it is. So 4 years ago, this trust spent over £80 million of money that it didn't have. Last year, that number was near 30. The reason for that is there are many reasons for that. One of them is what we call the structural deficit. And so, for our population of 360,000, if we were in the middle of Hampshire or Kent or Nottinghamshire, then we would build one hospital for a population of 360,000. Probably not a very big one, actually. But we're not. We're in the biggest landmass of a trust in England. We've got 1,000 square miles, and we've got a split of coastal, urban, rural, and so we run 3 hospital sites, and we will always run 3 hospital sites. To do that, though, comes at a premium. To run 3 sets of outpatients, 3 sets of theatres, 2 emergency departments, and an urgent treatment centre comes at a premium cost of around £25 million a year. So that's been recognised. Government has very positively resourced us to close that gap, so we're in a much more realistic financial position. But there's still more for us to do. We're under real financial scrutiny and pressure. I'm hoping to break even this year. That's the plan. And so there is much for us to do to reduce the money we spend. Follow on that. And then finally, is an acknowledgement that sessions like this are good and the right thing to do, and we enjoy them. We feedback from public staff, members of parliament, councillors come to them, but they're on teams and they're infrequent and they're a bit structured. So there is a real drive from us now to do different, and that will take years, not months, and it will be small groups. It will be the theatre coffee room. It will be the staff canteen. It will be the outpatient department with smaller groups of staff. telling shorter versions of this story in a more conversational way, and not just this story. It's not about us telling the story, but speaking with the organisation differently. And the same applies to our communities, particularly through the elected members in those communities. So that's all I wanted to say at this point. I get on about patients, but I'll pass now to Lynn. Thanks, Lynn.
Sorry, still on mute. Hi, my name's Lynn Wire and I'm the interim chief nurse. I want to take you through a couple of slides which are talking about the work that's the Chief Medical Officer is leading on clinical service reconfiguration and how we standardise some of our surgical pathways. I want to talk about two pathways in particular. I'm going to talk about trauma and orthopaedics and gynaecology. You'll be aware, I hope, that we've got an accredited surgical hub at Kendal now. And for both of these pathways, we want to make sure that we optimise the use of those for the benefit of patients. So this is to improve our services, to carry out more surgery in the surgical hub, and that will help us reduce our waiting list and obviously the length of time that patients are waiting for surgery. We are going to use benchmarking, already started to use benchmarking, particularly using the Get It Right First Time approach. And I know, Rhiannon, you'll be part of this and making sure that we've got really good pre-op preparation for those patients, particularly from an orthopaedic point of view. And then after surgery, from an AHP point of view, really good input to make sure that those patients are mobilised and out and ready for home. Our length of stay is slightly longer than it needs to be. So we're looking to reduce our length of stay, and some of the things from a theatre point of view, we've got 4 primary hip or knee operations on all day lists now, which is a big improvement on some of those lists. Previously, there were only 1 or 2 joints on those lists. And also to reorganise how we manage our outpatient clinics prior to coming into hospital, but also the potential use of virtual wards when needed for early discharge. So we're looking to get patients home more quickly and make their experience better. Next slide, please. And again, so this is gynaecology, and again, through the use of the surgical hub, how we can improve the throughput of gynaecology patients, reducing the waiting list and improving the experience for the patients on those pathways. So looking to carry out more day cases so that patients could go home the same day, but also what are we doing in a hospital environment that we could do in an outpatient environment. And also Helen Skinner would talk about some of the work that the GP practices are doing around ring pessaries for women. It prevents the need for them to come into a hospital environment or an outpatient environment to have those pessaries inserted, and increasing the number of operations we use using keyhole surgery, laparoscopic surgery. I think that's there's one other which isn't on these 2 slides, but a piece of work going on with children and young people, particularly around the use of virtual wards for paediatrics, and also development of a paediatric same-day emergency care centre. We have an assessment area at the moment, but if we implement the SDEC approach, that will make sure that patients are assessed early enough and hopefully don't need admission into hospital. They'll get worked up and then hopefully be able to go home. And the implementation of virtual wards for that group of patients will also mean that they're more comfortable in their home environment. Thank you. I think I'm not sure who I'm handing on to now. Estates.
Yeah, I think. So this is quite a discrete one. There's obviously much more we could say about our estate, and will at a future point. The specific focus here has been for us, and I talked earlier that for every pound we spend, we should be trying to make the maximum number of pence of that pound on patient care and patients. And we were in a position where that wasn't necessarily the case with some of our transport and estate infrastructure. So the changes we made this year, and difficult for colleagues that have worked there because they reorientated to somewhere else has not been straightforward. But the building at Moor Lane Mills we no longer use, and it was not it's a beautiful but not a particularly functional building for the colleagues that were there. And secondly, the premium cost of that was significant. So we out of that space. More broadly, we're looking at a whole number of other options around the estate. And the other thing was our transport. So we were spending many millions of pounds on transporting patients in a way that wasn't great for them, and was spending a lot of money. So we've got the almost ludicrous situation of having had ambulance transport to go up and down the hill on the RLI site, travelling. I think somebody measured it as something like 26 yards between the main Centenary building and the MU2 building, and spending millions of pounds a year on that. Now, that's the patients who need to go between those two sites. That's really important. Or sorry, two buildings. Sorry, not sites. So we found alternative ways to do that, that still get the patient to the right place. We've had to change the cohorts of patients that go to the MU2 to make that as minimal as possible. And also our use of taxis. So we have quite honestly lost all sensibility around our use of taxis, and so the many millions of pounds we were spending on that was not okay. So we're now very clear that ambulance transport, taxi transport, is a clinical support. It's not a social support, and that's not in any way sound unkind, but the spending NHS money on the way we transport was not going to be okay. So we made some changes in that space. And I think I'm on to Ali.
Thanks, Scott. So I'm Ali Bolton, Chief People Officer. I'm going to talk you through some of the digital elements. Ailsa, I don't know if you can just move the slide on. Thank you. So just as a recap, one of the biggest digital transformation programs we've been working on for this year is ambient voice technology. That is software that sits on a mobile device, a laptop or a computer, and can transcribe the consultation between a clinician and patient, and then it populates that into predefined templates, whether that be clinic letters or clinical notes. And that then enables us to provide real-time information to patients in terms of their almost real-time. Once it's been checked by the clinician, the clinic letter is there and available, and it's also then able to be sent to the GP without delay. So we've been doing a proof of concept. So we've completed that. We finished that in August in 4 specialties. We've had some really positive feedback from clinicians involved in that process, but also some really important learning for us to make sure that as we do the rollout, we can make sure all that learning is built in. And we're going through a process of purchasing this software now across Lancashire and South Cumbria as a collective arrangement with the other trusts. And we're coming to the end of that process. So we've whittled down from what could have been around 500 potential suppliers to 6, and we're in that final stage of the process. We'll know what our preferred product and supplier is in mid-November, and that means that we can then start the implementation of this proper for the last quarter of this year. We're going to make sure that it links and interfaces directly in with our electronic patient record systems to make sure that there's no extra friction, no extra activities that people are having to put into place. And we envisage that this is going to be something that has benefit for use in outpatient, in ward areas and in community services, so across the organisation, and not something that is just going to be for the doctors. It does mean that we're going to have to make some changes to the medical secretary workforce, particularly because some of the kind of transcription and typing activities that are currently performed will be done by the technology. So that does mean that we'll be going through some workforce redesign there for the medical secretaries, and we'll do that in accordance with our policies and be as compassionate as we possibly can in that process. Patient engagement portal. This is something that we've trialed, and something in a particular specialty again. In most things with digital, we try it in a particular area so we can test it, make sure we do the learning before we do wider rollout. So this is where we've made our letters available to patients electronically through the patient engagement portal that's accessed through the NHS app. And that means that patients we're not having to send letters, hard copy letters by post. So it's got a financial benefit, but also it's quicker for patients to receive that because they can get it in that real time on their through the NHS app. We're going to be expanding that now. That's worked really well, and we've put some real guardrails in place to make sure that if a patient hasn't accessed that within a certain number of days, that we'll send them a hard copy anyway. So we're making sure that nobody's at a detriment. We've also started some self-booking options through the patient engagement portal, and we'll be looking to expand that further. And that's important because we know when patients have the option to book their own appointment at a time that's convenient to them, it means that they're going to turn up. The likelihood of them turning up is much higher. So we see a lot lower missed appointments if we allow patients to make that choice for themselves. And then the other one on the patient engagement portal is around the digital inclusion passports. So whether you're a child or a young person, you're somebody who's frail and elderly, or maybe have learning disabilities, you can put into the passport the things that concern you, the things that you would like to see, anything that is your particular preferences. And again, that's now available in our electronic patient record system, but also through the patient engagement portal through the NHS app, which means that it can be shared then by the patient with NWAS or primary care or pharmacy or anybody they need to, rather than having to keep going through the same things over and over again. And then in the non-clinical digital assistant space, we've been working with NHS England and one of Microsoft's partners to do an awful lot of the preparatory work to be able to start launching a digital assistant for human resources. So that will mean that colleagues will have access to policy and terms and conditions related information through a chatbot functionality 24/7 without having to fish through all of the various policies that we have. And we're just ready to start our formal testing of that over the course of the next few weeks. And we're also looking at where there could be opportunities for us to use that kind of technology broader. So not just related to HR, but actually there could be some things that we're able to do in lots of other areas of the organisation to make things more accessible and easy to access for colleagues. I'm going to hand back to Scott, I think.
Thank you. Outpatients. So first thing to say, because it's not doesn't jump out on the slide, is that absolutely with more to do because we are not hitting the targets, which are the right targets. The targets that exist nationally for elective care are the right ones because they get patients access to our services much more quickly. But pound for pound, we deliver really pretty good access for our population. So our waiting time for outpatients, for diagnostics, cancer, for elective care, including surgery, are good, and our process measures in terms of how we utilise outpatients, book outpatients, utilise theatres are also good, but they're not the best, and we want them to be the best. So the work we've done in this space for outpatients, you see the percentages when you look at outpatients and you think it's only a couple of percent, but actually that's many thousands of patients because we see many thousands of patients every year. So the first one's on advice and guidance. We are good at advice and guidance. So 50% of our referrals we're seeking, of 48, to get to the point where it's not just a simple dear doctor, I saw Scott in clinic today, can you come and see you? It's well, I saw Scott and he might need to come to hospital, but I just want a bit of advice on issues 1, 2, and 3. And if the clinician in the hospital can do that, he's got proper dedicated time to do that, then it means the GP gets good advice. It means the clinician to clinician dialogue is learning. And it means that the patient doesn't have to come to hospital unnecessarily, and that the patients that do are more appropriate use of that finite resource in outpatients. So The goal is to get that from 45% up to 48%, which is many thousands of patients being having advice and not coming to see somebody unnecessarily. Patient-initiated follow-up, the gone are the days we hope, and we certainly should be, where you had your index condition and you come up and see someone in clinic and they don't feel like very much has happened to you, don't feel like you have to come to a hospital for it to happen, and you say, I'll see you in 6 months just to make sure you're okay. That's not good for patients, and it's not good for our use of what is a finite resource. And so we are good at PIFU. We're one of the best in the country at PIFU. And we are well above the 5%, which is the national ask. We're at about 12%. But we, rather than sit on our laurels with that, which we are good at it, but it's by less than half of our specialties. So we are at 18 specialties using PIFU, and we want to get that up to 27 specialties. So that we really have a big hitting. A big area of focus of us is going to be gastro and gastroenterology, where we see a big opportunity for this. And so that means patients have had the condition within 12 months, they can phone up and say, I've not got an outpatient appointment booked, thank you. But I think we need to come back and we'll have a discussion with the patient to come back for their own volition. And that's probably much more clinically accurate than it was just within 6 month appointment. And in missed appointments, we're doing some really exciting work in this space. So in old money, these would have been called do not attend, or DNA patients, for children was not patients. Both quite good expressions, actually. So for missed appointments, we were at a point a couple of years ago where around 1 in 10 patients missed their appointments. And that number today is near 6%, it's like 6.4%, which is really good. That's lower than the national average, and we've seen it reduce, which is good. But it's still 1 in 20, more than 1 in 20 slots where the patient doesn't come. But that's not the patient's fault. So there are things we need to do to try and get that number even lower. There's some obvious things we've seen for many years now, phone calls, text messages, that makes sense, but there's increasingly some real intelligence, as in human intelligence around this, that it's much more nuanced than that. So we've got some very good people focusing on this as a general issue, and specifically focusing on the core 20+ population, so the population who are most deprived in our communities. And we've got a different approach to that population, which we've been exploring with our expert public health colleagues. Because when I said it was 6% of the whole population for missed appointments, it's 10% if you're in the by 20% of the population. So we're using predictive technology to identify the likelihood of a patient not coming, based on postcode, health history, and other indices. And we're then using increasingly some software to figure out how we best communicate. Apparently, the type of words you use, the order you use them in, the time you send it at can be really important, depending who you're sending communication to. So we are trying to identify these groups of the population and then communicate them in a bespoke way. It gives them the best chance of attending them if they've got an appointment. And I think I finally hand on to Lynn again.
Thanks, Scott. So I'm just going to talk about a huge piece of work that is ongoing around reducing the number of patients who are classed as not meeting criteria to reside. So this is a group of patients who are in our acute hospital beds that actually would benefit from being at home or back in their residential home or their care home. And at any one time, we have about 140 patients across the bay who don't meet criteria to reside. They've had everything done in hospital that needs to be done, and they are just waiting for something to happen to go home. And that's about 27% of our bed capacity, which is phenomenal, really. So we're doing a lot of work across the multidisciplinary teams looking at this. It's very, very complex. But we met recently to develop what we think there are a set of high impact interventions that we think will make the difference over the next few months. I talked about virtual wards earlier, but we need to expand those to general admission and not just speciality admission like respiratory. There's an additional 25 beds, virtual beds coming online in November, and we want to increase the utilisation of virtual wards, and in particular for admissions avoidance, not just for discharge. We can use, when patients are discharged into virtual wards, it could be weaning from oxygen, it could be IV antibiotics, where normally they would stay in a hospital bed. The second thing we're doing with the Chief Medical Officer is developing a set of internal professional standards. And this is a suite of interventions that would be standard across all ward areas. And I'll just give you some examples. So that we have ward rounds implemented before 10 o'clock. And then the notes are updated in real time. And Ali talked about some of the opportunities from ambient voice technology, and we're really interested in looking at whether this will make a difference and make it easier for the clinical staff to update the notes contemporaneously. And then observing the dynamic board rounds. So these are multidisciplinary perspective, looking forward about what will happen to the patient over the next 24 hours. We've been doing a series of observations. We did our third one today on Ward 35, and every time we learned something new, whether that's a really good practice that needs to be shared elsewhere, or things that are really difficult to discharge patients at ward level that we need to help unblock. We talked about benchmarking a little bit earlier, using the model hospital and get it right first time to just benchmark our length of stay. Increased use of hot clinics for patients who are waiting in a hospital bed for things like scans that could go home with an appointment to come back. Re-looking at our discharge coordinators, they do an absolutely fantastic job down at ward level, and we need to get them to concentrate on the very simple discharges that can go home. And a third attempt, I think, so over the last 7 or 8 years, we've tried 3 times to implement criteria-led discharge. What we realise is that in some places it's working really well. We went to Ward 35 today, and they talked. Their dynamic board round was brilliant, really well managed, and they talked about criteria-led discharge in preparation for the weekend, and that's the first time we've heard that utilised so well. So we want to roll that out. So this is where nurses just need a set of instructions from the medical staff. If this happens, the patient can go home and they don't have to wait till the next day till the medical staff come. And the nursing staff are really keen to develop that. And then throughout all of this, for those patients that are required to stay in our hospital beds or do stay in our hospital beds, we're doing a piece of work around prevention of deconditioning, the use of active wards, making sure people can get up, get dressed. And one of the things that we're doing when we're out and about is looking at what percentage of the patients that are up and dressed on the wards, accepting that, you know, they're very busy places, but it's better for the patients to be more mobile and active. Thank you. That's all I have to say.
Thank you very much. So that concludes the slide. We'll be back in updating on the things we've updated on, and of course some new things in February or March. And we'll take down the slides. Then really keen to hear any feedback, comments, questions about either what you've seen or not. Or so anything different you want to talk to us about. So over to you. Can I chat? Leanne?
It was just a general observation from working from a medical education point of view. It is actually quite interesting to see and hear what's going on in other departments and what the work is, and sometimes thinking about how that could potentially link in with our medical learners. So just thank you for sharing that. I find it really helpful.
Thanks, Leanne. I appreciate that, and it's a great point. We didn't say it overtly actually, but we say it often, and actually it's one of the questions the board asks a lot is, given all of the above, what does that mean for the future shape of our workforce?
Yeah.
And a very good example of the 10-year plan we will need very different ratios of what our current clinical workforce looks like, and they'll need to have a different set of skills. We'll always need people that can do laparotomies and people that can care for patients, you know, in the bedside at the home, but it will materially affect the shape and size of that workforce. So it's a really good point. And actually, the live example, we didn't present it here, but we're going to really try and get the story out about it. The piece of work we've just done in Barrow and Furness around what we call the integrated wellness service, where taking patients that would have been very frequent attenders at hospital and admitted to hospital frequently in our kind of traditional medical model, now being cared for very differently by what we call place workers, pharmacists, therapists, nurses, with some medical input. It's a very different, the same patients are there with the same pathologies, but there's a very different approach. So the skills and are very different. So, you know, it's a point really well made.
No, thank you. And sorry, I couldn't put my camera on. It's not allowing me to for one reason or other, but
It must be a few things. Mine's been the same, so I'm not.
thank you.
Susie.
I put a few things in the chat, but I'll say them. Okay, so for a start, looking at the 10-year plan and looking at the 3 shifts that we are working towards, are there any other countries that have universal healthcare in the same way as we do, paid for in the same way as we do, that actually do this? Are there any? I was wondering about the Scandinavian countries. Do any of them have this new model that we're working towards that we can learn from?
So I think yes to the second part, perhaps not to the first. So because you're right, Scandinavia is a very good example. I did some of my postgrad studies in Denmark and Norway, and there is very much that model. The best known one's the Buxog model, and it's but it is in a hybrid funded system where there's access to private healthcare for hospital care. So in a fully tax funded system, I don't know of any, but there's certainly enough exemplars of kind of hybrid systems where they've done exactly this. Alaska is another very big one. The Population Health Collaborative in Lancashire have got very good connections with the nuclear system in Alaska, who've done very similar things in a much bigger geography. So yeah, there is definitely some things to know.
Yeah, I mean,
sorry, should I be quite? I'm quite sure if you looked at the list of references in the 10-year plan, or certainly some of the King's Fund or Nuffield Trust documentation around this, it will definitely reference the Buxog model, Alaska, and others. So there are certainly some principles from that.
Yeah, I mean, I think we need to talk about, you know, what's happening elsewhere, where it is going, and how it's worked, to be able to say, look, be more like Alaska. God, I never thought I'd say that, but there you go. It's America, for God's sakes. Anyway, but you know, something like that we can actually see the model in work and demonstrate that it does work and that it is better for patients and clinicians as well. Yeah,
I've seen your question down. So your second one was about surgical hub and places are more likely to be seen in WGH than in Wrightington or Preston. Yes, in the main, unless they've got specialist things that are required of them. So obviously, if it's like a second revision of a joint or a complex pathology, then there'll still be specialist patients sent certainly to Wrightington, and less so Preston actually. So a couple of bits on that. So the surgical hub in the round, absolutely. So as a very crude number, we are operating on more patients here now than we did before the surgical hub. In a session, we're operating on more patients than we did in a session. And we are filling our most expensive capacity in the NHS in a theatre. We're filling that better than we did before the surgical hub existed. So yes, and yes to all of those. There's also Helen's Skinner's really accelerated some of the work on using the national best practice and benchmarking around getting it right first time. In our orthopaedic clinics, it really is now pretty much a must do that there's 8 new patients and 4 follow-up patients. That 8 plus 4. We had times in the past where that might be 5+2. So we're having fallow slots in our outpatient. Likewise in theatres, 4 joint lists as they're called, and they've been around for many, many, many years. We were there, not fully there yet, but we did this time last year have 3 or 4 clinicians doing 4 joint lists. We've now got 8, and the aspirations to have 12 to 15. So yeah, I think yes is the answer. How does moving the hospital care team to the council made a difference to discharge? So what was called the hospital at home team, again, very good people doing very good work with a complex group of patients. It was the downside of that was it was a layer of kind of failure demand, and so it existed because it was impossible to get patients into social care. And so they were kind of held in an NHS service where the patient need was either domiciliary intermediate care or residential intermediate care. And we did start to butt up against some real, I guess, kind of moral issues almost of areas that don't have that service, or even within our trust, if you weren't in that service, there's a difference in means assessment and continuing healthcare assessment and what fundamental rights patients and families have in the law to social care and other things. So it started to really become quite an inequity depending what part of our system you were into. So I guess having the bank account scrutinised depending if you were in that bit of our service or that bit, and that's challenging. And of course the synergy with what they should be doing is of course with a local authority, because that's where the intermediate care and so on happens. And so that's the rationale. And of course that was something that people relied on. And so it's taken a bit for people to get their heads around, but what do we do now then if they don't exist? And as Lynn spoke to him, that 90% of hospital discharge stuff are the nurses, therapists, doctors, patients, families and wards. And the more bespoke things we have, creates some of the results that we get. So yeah, just it helps us declutter some of that and ensure the right people are engaged in the discharge. Lynn, anything you want to add to that I've missed or got completely into it?
No, you think you've answered it really well.
Oh, thanks. Appreciate that. Melissa, the pieces of the shard will use virtual beds. Is there anything to ensure you aren't been subject to abuse? Lynn?
Yeah, so I've been reading your question, Melissa, because it's quite it is a challenging question, and so there will be those patients that have been assessed as vulnerable or at risk that we will need to make sure that that they may already have safeguarding processes in place, so we'll make sure that carries through. But for those patients, everyday patients, we don't always know what the home situation is. I was talking to the safeguarding team yesterday, and one of the things that they're going to introduce is a question which is related to do you feel safe? And it's almost while they're on their own to start that conversation about, and that would be a particular conversation that you could have before you discharge patients, whether they need any additional support. But you raise a really interesting question about we never know what people's home circumstances are, do we? But we need to be mindful that around different forms of abuse for patients.
Yep. Thank you. Susie?
Yes, around that, I saw somewhere, I don't know whether we do it, where if the patient is being asked for a urine test, for a urine sample, that when they go into the cubicle, they are given, there are 2 pens. There's a blue one to give, put the name on, but if you write your name in red, that tells the team that they should make an effort to make sure that you can be seen on your own. So in other words, that's a red flag, obviously. Do we do anything like that? And is there that's the sort of way, because the difficulty, isn't it, is asking the question, but also doing it in such a way that if in domestic abuse cases, often the partner will insist on being there.
Absolutely. Yeah. And I don't think we do that, Susie, but I will pick it up with the safeguarding team because some simple stuff, isn't it?
Exactly. It's simple things, just to signal. I mean, you know, in the pubs, some pubs now do this thing about asking for Angela.
Yeah.
You know, we need to do something like that, where our patients know that there's a code word they can use, or something that the husband won't have seen that they can ask, and it can be, you know, it can be actioned.
Absolutely. Great question. Thank you. I don't see any more questions in the chat. If I'll ask again if there are any, so if there are, I think just now, but if not, you've got all of our names on the screen. To drop us a line if there's a question, suggestion, feedback on how we do these sessions. Genuinely, please, we do want to hear that. So drop us a line. But just before we have got time left, anything anybody wants to ask or say before we come to our close? Well, listen, thank you. Actual job. This is our job to do this. So this is the one thing we've got other jobs as well as coming here for an hour. So thank you very much. I appreciate your time, and it's good to speak to you. Thanks very much.
Thank you.
Bye now.
Thank you. Bye.
Right.
Okay.